As Judy said, I'm Kevin Borcher. I'm responsible for the prescription drug monitoring program here in Nebraska. Have a few other duties that I do as well. I'm on the Nebraska Board of Pharmacy. I'm involved with several national organizations with PDMPs, or some of your states call them PMPs, and we'll get into that. What I wanted to do today is talk a little bit about the drug overdose problem. Specifically, we know opioids. Talk about prescription drug monitoring programs that we see, sort of the pros and cons, the comparisons and contrasts across the country that we'll see some of these. And then how do you, as pharmacy technicians, have the capability to use this as a very valuable tool as you're practicing for patient safety? Everyone heard of the opioid crisis? Don't want to get into all of the details of that, but of course we know it's a huge problem. CDC just released information earlier this month that they've seen a significant increase in the number of drug overdose deaths in 2020. In fact, it was a 29.6% increase from 2019 in drug overdose deaths totally. Typically, we'll see about 28% of those attributed to prescription opioids. Now, the numbers are actually a lot higher when you look at all opioids because of what type of opioids do you think are causing most of the deaths? Illicit drugs, your fentanyls, heroines. The stimulants are making a big comeback too, the methamphetamine. But there has been a decrease that we've seen overall in the past few years. I think 2020 was an anomaly for a lot of reasons. We've seen about a 25 to 30% almost decrease in prescriptions for opioids. This is specifically a Blue Cross Blue Shield study they looked at a few years ago, that they saw a nice decrease in prescription opioids. That's wonderful. But we're still seeing projections of increases in those overdose deaths. And why? Once again, look at that yellow line. It's those illegal drugs. So wouldn't it be nice if we could have laws that drug dealers on the street needed to report their dealings, right? Their fentanyls. And because they're stupid criminals, I can bet you that some would actually do it. But we don't only see the opioids and now the stimulants as well, but benzodiazepines. Usually prescription, but some people go outside of the norm to get those. And this is becoming more and more of a problem, especially benzodiazepines in combination with opioids. And the CDC has identified this as a major contributor to opioid overdose deaths. So as you're dispensing prescriptions to your patients, you might want to pay attention if they have combinations of opioids and benzodiazepines. I'm betting most of you have seen something like that, right? It's not, unfortunately, that uncommon. But it's something that, as you're using some of these tools to bring up to the pharmacist and help them use their professional judgments to see what's going on. The opioid crisis didn't start with one single event, did it? And it's been going on for quite some time, I mean, decades. And it's not going to be solved with one event either. So we have several pieces that we can look at. Prevention, education, treatment and recovery, and that's a big piece, and then identification and monitoring. When we're looking at prevention, a lot of you may have done that. So how many of you work in community or ambulatory settings? A few of you? Hospital? Okay. A couple of you are in veterinary pharmacy practice settings, right? Okay, good. Most of you, if you haven't been directly involved with these, you're aware of it. The drug take-back programs. DEA has these usually about 4 times a year. You'll hear it on the news, on the media. And they're great to get these drugs out of the hands of people who have no need for them. And a lot of the pharmacies have methods to dispose of those. They'll have these envelopes that patients can come in and say, I have this unneeded whatever it is, Oxy or Xanax. And so you can have those in these bags that you can give to the patient. They can put those in and seal it and send it off to the DEA. Other law enforcement agencies can also take care of these. So this is important because you don't want unused drugs in the hands of people who don't need them, right? And a lot of these issues, it's friends and family members who are responsible for taking a lot of these. So if, let's say you had shoulder surgery and you had some hydrocodone, and this is, I'll tell you what happened to me several years ago. Had shoulder surgery. My doctor gave me oxycodone extended release, oxycodone immediate release, hydrocodone AAPT, and gave me some tramadol too. And he was very nice enough to give me some ondansetron for the nausea I'd have for all of those, as well as some Colace, so I wouldn't have to deal with some of those really bad side effects. How much did I really take? Oh, probably for the first day, I took enough to get me not pain-free, but managed. The rest of it, I had no need for. So what if I left those in my medicine cabinet? And let's say that I had children or grandchildren, and they come into the house, and they get those. Or you have your house going up for sale, and be it a real estate agent or during showings, people will rummage through those drawers and find things like this, and they'll take them. Hospice patients, those patients who have recently passed, the family members have no need for these drugs. And you want to get them out of their hands as well. And that's where working with hospice programs can help with this. Education. What are we doing right now? We're educating on some of the challenges, the problems with opioids. And this goes back to elementary school. You could be talking about third graders on this. And this is an opportunity for you that you can go out to your schools, your community, and talk about the dangers, the just say no if you remember the Nancy Reagan era. And I don't think hardly any of you do. But this is important to get them out of the hands of people and to educate them. Treatment and recovery. Once again, this is probably a mainstay of where you need. And I'm going to talk about Naloxone here for a minute. So have any of you dispensed Naloxone to patients? Okay, good. Then you're aware of some of the different types. There's a needle and syringe. Some pharmacies will either use these Carpijacks or Tubexes or IMS type products, and they're very inexpensive. And you can find that from, let's say, a good RX coupon for $13 to $15. Pretty inexpensive. But let's say you're someone who's trying to, you find someone down on the ground. And if you're a female, maybe you have a purse, maybe not, maybe either a male or a female, and you have it in your pocket. You're going to have this big thing sticking out of your pocket, bigger than your cell phone. And it's not very convenient. And then you're struggling, and you're in a panic state, right? Because you see someone down, and you don't know if they're dead or what to do. So you happen to have this, and you pop the top, and you're trying to put it together, and you're shaking, and you're not sure what to do about that. And then you're going to stick it in their arm or their thigh, and you accidentally stick yourself. Good thing is Naloxone won't really hurt you, except for the injection, but it's not going to help the person who's down that may need that. There's another product available called Evzio, that's the brand name. Still it's Naloxone, and it's in an auto-injector, similar to the EpiPen in concept, where this is even more advanced. It'll actually talk to you to push the red button, place it on the patient's thigh, leave it there for 10 seconds. And very great product and concept. But has anyone looked up the cost of this? Anyone want to take a guess? We're going to play the Price is Right if it's higher or lower. Any ideas? Higher. 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 I'll give you that. Talking to several different pharmacies in this community, it's anywhere, patient cost is between $4,200 and $6,200. Now, the good news is that there is a patient assistance program. Wonderful. The bad news is that the criteria to meet to have it covered is rather steep. So it's still got a challenge. Great concept once again, maybe not the best product. But there's a third product, Naloxone nasal spray, and it's generic now. The cost of this is going to run anywhere from, last time I priced it out, $120 to $150. So not terrible, still a little expensive. Insurance will typically cover this product, not in all cases, but in many cases. And many states have a program where this is actually free. So you can, and you don't need a written prescription from your doctor to get this. You can go into a pharmacy. Most states, not every, but most states have laws on the books where a patient, a friend, or a family member, or a caregiver can go into a pharmacy and say, I'd like to get Naloxone. No reason, just I want to have Naloxone. And they'll fill it. They'll maybe even run it through your insurance, and you might have a copay, or maybe it'll be free. I did this myself. I had a $50 copay for my insurance. But now I'm able to carry around the Naloxone nasal spray. And if I see someone down, it's very similar to like Afrin or Flonase nasal spray. And it usually comes in a 2-pack, so it won't last that long, but enough to get them out of their opioid-induced coma. You can call EMS, and if they slip back into that coma again, you can give them another dose. EMS should arrive by then. Very good product. Law enforcement typically will carry this with them. And then I wanted to talk mostly about today the identification and monitoring of patients who may have substance use disorder, opioids, benzos, whatever. And this is about the PDMP. So how many of you have heard about a prescription drug monitoring program? That's great. How many of you have actually accessed or used the PDMP? That's really good. Hopefully we can get that number even higher after you see the benefits of this. So a PDMP, and once again, some will call it a prescription monitoring program, others PDMP, goes by any other name, right? It's just a big electronic database. And pharmacies will send this information to the PDMP and allow usually prescribers, pharmacists, and their delegates, such as pharmacy technicians, to access this. This shows the number of states that are required to report to the PDMP. Missouri, anyone from Missouri here? I don't know if there's anyone online. So Missouri is the only state without a statewide PDMP. They do have a county-by-county PDMP, a little bit different, but it's very unique. That has changed as of last month. They did pass a law where Missouri is going to turn blue. And that's not political. Everyone is going to have a PDMP now. And it's going to be able to be shared with that data across the country, just as other PDMPs work. So that's some really good news. The process of this, so it's like the data gets there, right, and what happens with it. So if we start in the upper right corner, patient has brought in the prescription. Well, it gives you the opportunity as the pharmacy technician to look up their PDMP access, or I'm sorry, their prescriptions. And these are primarily for controlled substances. Patient can get the prescription if everything is correct, and then that data goes into our PDMP database. down here. There are a lot of analytics that can go on that's reported out to the state and to the providers to look at their prescribing practices as well. Then, if a patient has an appointment with a provider, they can look up that patient's PDMP report maybe the day before, the morning of their coming in. If they see some unusual activity, they can make some calls. It's like, I'm seeing patients who are going, it appears to be pharmacy hopping and doctor shopping. It gives them the opportunity to contact those pharmacies or those other prescribers and see what's going on. So when the patient comes in, it gives them the opportunity to say, I'm seeing some unusual activity in your PDMP report. Help me understand what's going on. Are you at a university teaching hospital where you see new medical residents and doctors every week for a 3 or 7 day supply of your oxycodone for chronic pain, which is legitimate? Or are you trying to circumvent the system and get drugs outside and you think you're getting away with it? And if that's the case, you can get these people help. You can refer them to a substance use disorder program, opioid treatment program, whatever they may need, community resources to get them help. Why do we need the PDMP? Well, make sure the patient receives the appropriate therapy. It's primarily, and this is virtually in every state, it's to prevent the misuse or abuse of controlled substances. Diversion, fraud, forgery, the doctor shopping and the pharmacy hopping. It can help to identify that fraud and diversion. It's also used for patient safety. It can be used, and we're seeing this more and more across the country, for public health, but patient safety. And when I talk a little bit about Nebraska's program, that'll help to bring it back into focus a little bit more. So those three pieces are very important to this. What needs to be sent? So you have 4 different big elements that you send. You send the patient information, their name, address, date of birth, their pharmacy information. What pharmacy are they getting this prescription dispensed from? And we can track that by DEA or NPI number. The prescription information itself, from the date it was issued or written, when it was filled, when it was sold. So you can identify not only the day it was written and when it was filled, but when did the patient actually pick it up? Or if you're a mail order pharmacy, when did you send it to the patient? And it has a lot of other information too, including payment type. And this gets very important too, because patients will typically, let's say they're Medicare, Medicaid, commercial, and it'll show that. It'll also show if they're getting prescriptions through cash. So if you're looking in the PDMP, you might see something where the patient is getting their alprazolam and they're getting it twice a month. And it's commercial, private pay, commercial, private pay, private pay. What's going on with that patient? Is it that maybe they switched jobs and they're in that period where they have to pay out of pocket? Are they getting different insurance at usually the first of the year, right? Which you all have this hassle of trying to fix insurance plans and re-adjudicate and reprocess those in your systems. But it could be the patients think that they're flying under the radar again, and you can't see that information. You can, and you know about it. And you can bring this up to the pharmacist as you're looking at their PDMP profile, as you're assisting the pharmacist. Pharmacists can contact providers. You could see if there's an insurance problem. A lot of different reasons. Maybe they have a discount card that they can get it cheaper. And then it has the prescriber information, of course. What drugs are typically monitored? Well, as you can see, it's controlled substances throughout the country. Sometimes it's Schedule 2 through 4. Other states require 2 through 5. So it has that promethazine-containing cough syrups in there. You'll also see drugs of concern listed here. A drug of concern is something that has an abuse potential, but it's not federally monitored as a controlled substance. The big one that we're seeing now, I'm not sure if anyone has experienced this or run into it in your PDMPs. Have you experienced or seen anything where it's a non-controlled substance but is considered abusable, or you might have heard on the media? Perfect, gabapentin. That's the big one that some states are actually scheduling that internally. Still federally, it's not. There's a lot of information showing that it is abusable. Patients who are not able to get opioids will gravitate to gabapentin right away. It used to be tramadol back about 7-10 years ago before it was scheduled. And tramadol was a drug of concern because everyone knew that it had abuse potential. Eventually, the DEA did schedule that federally. Gabapentin, I'm not sure where it's going to go. But then we have in the purple, Nebraska. Nebraska has all prescriptions. And I was a little upset with the organization that scheduled this purple because I told them I wanted it Husker red. And they said they wouldn't do it. So I said, how about another thing? How about Creighton Blue Jay? Let's do it blue. They still wouldn't go for that. So we compromised on purple, red and blue. And I was okay with that. I'll be coming back to that eventually. As other states are doing this, and this is important to know that Nebraska right now has all prescriptions. Colorado last month passed a bill. Anyone from Colorado? Good. So I don't know if you've heard anything about this bill. In July, their legislature passed to go to the Board of Pharmacy to allow for all prescriptions to be dispensed and to be put in the PDMP. I testified on this bill, and there was only one individual who had some concerns about this. Everyone else was in very strong support. So I think that it's going to go through. Politics gets involved, and I can't say it's guaranteed, but it's going to have a great benefit. And I'll talk about why, especially in Colorado, and those in Nebraska. Anyone from Nebraska? Good, a lot of you. So you probably already know, and I'll ask you specifically why you see the benefits to that. How often is this data collected? Because if it's a week old or a month old, it's not going to do a lot of good to you, right? Almost every state collects their PDMP data on a daily basis, or at least a daily basis. Nebraska changed their law last year, and we said at least every day. But we said we'd like it more frequently because we like what Oklahoma is doing. Anyone from Oklahoma? You guys have it right. And once again, I don't think there was anyone from Missouri. Missouri passed their law last month, and in that allowing a statewide PDMP says that in 2024, all pharmacies have to report in real time to their PDMP. So Oklahoma actually reports within 5 minutes of it being dispensed to the patient. This is going to be real time. So think of your point of sale systems. You know, your barcode scan about everything all the way through the bottle, and then when they come, either your cash register is hooked up to your pharmacy system or you have a barcode scanner and you scan in maybe their patient ID. That sends the message at that time to the PDMP. So if you have a pharmacy that a patient might be trying to commit fraud or diversion, and they have a forged prescription, and they go to pharmacy A and fill that. By the time they walk across the street, maybe with a stoplight, to pharmacy B, because you know there are pharmacies on opposite sides of the street all over the place. By the time that patient gets over there, that drug can be in the PDMP and give you and your pharmacist an opportunity to see that. So you pull up the PDMP because you see it's a benefit for patient safety, and you see that they just 5-6 minutes ago had this same prescription filled across the street, and gives you an opportunity to work with a pharmacist and maybe with the patient. You know, maybe they have some legitimate reason, maybe it was a partial fill over there, maybe they have a forged prescription and you need to take appropriate action. Maybe it's contacting law enforcement, the state patrol, maybe you need to talk to the patient, maybe hold on to that prescription, whatever your store policy is on that. There's nothing specific, but point of sale is a great system to make this happen. Who actually reports to the PDMP? Well, I said pharmacies, which is true. All the in-state pharmacies, Nebraska, for instance, has about 480 community pharmacies. But mail-order pharmacies, too, have to report. Us, for example, we have about 600 mail-order pharmacies. Some states have hundreds and even thousands of pharmacies that have to report. Physicians that have a dispensing license have to report too. And doctors don't like to do this. So some of them get out of that business and redirect their business back to the pharmacies. Veterinarians, there are 15 to 18 veterinarians, states that have veterinarians report to their PDMP for their pets. And you might go, doesn't make a lot of sense. Yeah, it does make a lot of sense because there are unfortunately too many cases where pets owners will bring their animal in, and it might be something as simple as my animal goes crazy around the 4th of July or New Year's Eve, and I just need some alprazolam or lorazepam for my St. Bernard, or I need 2 milligram alprazolam tablets for my Chihuahua, and they'll go from vet to vet. There are other people who are much more despicable, and depending on how many hands I see raised, how many of you are pet lovers? Okay, then I won't go into it. Judy did not raise her hand, but I can tell you that the stories that are out there and the stories that I've seen and experienced are horrific. And those owners need to be kept on top of things, and veterinarians do report. And some veterinarians have the ability to look in your PDMP, and depending on the state, to see this, to try to stop some of these practices. Now, accessing the data, I said who reports, what's reported, who can see the reports. Prescribers throughout the country. It might be doctors, APRNs, PAs, pharmacists in virtually every state. Delegates. This is where all of you come in. Oftentimes a prescriber, a doctor may have a nurse looking up their PDMP because they only have a limited amount of time to see the patient, so they have a nurse look up that information. Like I said earlier, maybe the day before or the morning of a patient's appointment. But pharmacy technicians have a very valuable role in this, to look up this information, because the pharmacist is busy too. Either they're on their phone, or they're drinking their 4th cup of coffee for the morning, or they're just talking to someone else and not doing anything, right? Yeah, we all know better. Some of you probably think that, and probably some of you see that. But pharmacists typically do a good job, and they are busy and focusing on patient care. And this is where you can come in to help with that patient care. Some states do have law enforcement access to look for, let's say your Board of Pharmacy or Board of Medicine can have access. State Patrol, your state investigators have access. Some payers, like Medicaid, can have access to this PDMP data, but only for their beneficiaries, only for who they're covering. Because you've all heard of HIPAA, right? You only know HIPAA too well. Payers can have access to this data, but only for their covered lives, not just going out and on a fishing expedition. And then in some states, patients can actually have access to their reports. They may have to contact the Department of Health and request that, but they can have access to this information as well. You can't read this, and you're not meant to be able to read this, but you can go, if you would Google PDMP TTAC, you would be able to see different charts and graphs. And what this really shows is which states have access to which type of licenses, like pharmacy technicians, APRNs, PAs, payers. Can patients have access to it? So if you're interested in your state, who can have access to it, this gives a good opportunity to take a look at that. Now the expanded use of the PDMP, and this is big what Nebraska is doing, we were the first and currently the only state, and hopefully Colorado is going to follow us, to report all prescriptions. It's the most comprehensive medication history for Nebraska in the country. And how many of you are med rec techs? So, and how many of you are in Nebraska? Okay, so how many of you then have used the PDMP for med rec? So you've seen the advantages of this. You know that in either your hospital, EHR, maybe your pharmacy system, you have a fairly good profile, and it's only updated until the last time it's been accessed and updated. So this is great. It allows clinicians to make better informed decisions because you have more information. It goes beyond just seeing if your patients are using oxycodone or alprazolam or methylphenidate. You can see if they're on maybe other drugs that you weren't aware of. An example that we see sometimes is a patient who goes into their provider and they have a urinary tract infection. And the provider did not check the PDMP. So they get a prescription for an antibiotic. Makes sense, right? And the patient takes that to the pharmacy. And the pharmacy does not check the PDMP because you think that that patient only goes to your pharmacy and you have no medication, adverse events listed, no allergies or drug interactions that show up when you process the antibiotic. What happened though, the patient took the antibiotic, went to the emergency room about 2 or 3 days later. Nose was bleeding, bloodshot eyes, bruises all over. And it took a little bit of time for people to figure this out, but including the lawyers who sued both the provider and the pharmacist and the pharmacy on something like this because they didn't check the PDMP. And the PDMP is actually mandated to be checked by either the prescribers or the pharmacist in all but about 7 states. So there's really no reason to check it. Once again, we're all prescriptions. So if it was checked, they would have seen that they were getting that antibiotic that was in their hands or being prescribed, but they also had a drug they were getting from another pharmacy. Could have been mail order or could have been from the pharmacy right across the street or in town for Coumadin. And there's a potentially fatal drug interaction between some antibiotics like Bactrim or Septra and Coumadin. And on the Board of Pharmacy now, there was a case not too dissimilar from this where the product was not checked, the PDMP was not checked. And imagine if you did not check the PDMP and you knew this tool was available to you. And let's say the patient actually died. And in one case, I know the patient did die. There was a lawsuit brought, and the patient's estate won over $1 million. Now, the pharmacist and the pharmacy had liability insurance, and it was covered. But there is also disciplinary action that can occur against that pharmacist and that pharmacy. So it's really important to look at that. It's also a great tool for emergencies. And let me see. I just want to make sure time-wise we're still okay. And we are. 2 examples that happened locally. There was a pharmacy where their IT vendor wiped out their entire pharmacy software, including all of their records. And you're going, that's impossible, right? Because everyone has backups, and backups of backups, and backups of backups of et cetera. No, it was all gone and unrecoverable. So what did that pharmacy do? They used the PDMP as a type of a patient profile to at least understand what the patient has been on up to yesterday, or in some cases even the same day. And then they were able to call the prescriber, get new scripts written because they had no documentation of the old things. And they were able to minimize any impact to the patients. So when the patient came in to pick up their prescription from the refill they've had for years, it was ready for them because the pharmacy could work with the PDMP and their provider. Another case for these emergencies, and this happened in Nebraska within the last 12 months. A hospital, a big health system actually, with multiple hospitals, had a cybersecurity event. And so they had no information. It took them about 10 days to get back up to speed where they were, where things were working again. But imagine that if you had no data on your patient, you don't know what drugs they're on, what drugs they came in on. You don't know a lot of information. What's their diagnosis? So in Nebraska, we have a health information exchange where most states do have an HIE, where hospitals and clinics will send their health information as a central repository. And this health system used not only the PDMP to find out what prescriptions that patient was on before they came into the hospital, because it does not include inpatient meds, it's only outpatient meds, but they used the PDMP and the health information exchange where it had lab tests, it had diagnosis, histories and physicals, progress notes, imaging, which can save a lot of money because if you just had some lab test or maybe an MRI yesterday and this happened and the doctors had no idea what the results were because they can't remember it off the top of their head from so many patients, they can look up in the HIE and see this information. And in some cases, they can actually see the radiology reports, the MRI or the CT scan. So it's great if that happens or if there's an earthquake, flood, tornado, hurricane, whatever. And states will use the PDMP. Once again, other states only have controlled substances, which is still important, but as more and more states are looking for legislation, and there have been 3 other states that have introduced legislation on this too, Maryland, Maine, Connecticut to some extent, Rhode Island is looking at it. There are several other states that have contacted us. It's very great for this medication reconciliation in particular, because it's that very important tool. And if any of you do MedRec, isn't this how you spell MedRec? Isn't it a disaster? And once again, I don't care if you have the best EHR vendor system, and it's good, and I'll grant you that you have an EHR that has a pretty good MedRec system, but it's not great. It's, like I said, it's not updated. It's got a lot of problems with it. So you want this information updated, and you want it across the transition of care. You want it all the way in Joint Commission. If you've ever been in a hospital and you see the entire pharmacy staff, the director of pharmacy in a panic state because Joint Commission is here, they need to have these medication reconciliations through the continuum of care from the time the patient goes into the hospital, into the ED, or to a bed, if they switch from intensive care to a floor, and from discharge. This discharge MedRec is very important. And it's a mandate. So if you've not used the PDMP, even for controlled substances in your state, it's a great benefit. But if you're in a state that either has all prescriptions like Nebraska, or you're looking at having something like that, like Colorado currently, big advantage. Long-term care. How many of you work in long-term care? Okay, so when you get the orders from the hospital, not quite complete always. You might take hours or even days to get good prescriptions. So you're trying to use the discharge summary, and then you might look at the PDMP and you see conflicts. Well, was that because there was a formulary adjustment or therapeutic interchange in the hospital? And what are they really supposed to be on? Or is it duplicate therapy? So now it looks like they're on 2 antihypertensives, and their blood pressure drops, and now they're back in the hospital. So if you use the PDMP with all prescriptions, you can see this information and try to stop some potential adverse events before they happen. So some of the challenges, it's only as accurate as what you have. Once again, you're probably in your EHR, for those that use that, or even some pharmacy software systems use a type of a medication history, but it's not complete. It's missing some information. The patients themselves can't tell you, other than they're on a little pink heart pill, which in that one case was Coumadin. And if you're a pharmacist, you might have trouble remembering everything you're on. So I give them that. And then have you ever had patients bring in those bags or shoe boxes full of prescriptions? And you're trying to go through those and figure out what is what. And do they even have the right medication in the bottles that are labeled, if they're labeled? A bit time consuming also, not only to go through those garbage bags, but there was one hospital pharmacy that I worked with a few years ago in western Nebraska. And there were about 7 or 8 pharmacies in that town. And so what they did when a patient was admitted, every patient who was admitted to this hospital, the med rec tech would have to call every single pharmacy before the PDMP was up and say, you know, have you had anything filled for this patient? What was it? And so imagine you as a pharmacy tech and you're filling a prescription for someone who is sick because they have the flu or they just had surgery and they need their drugs. You stop what you're doing for that patient right in front of you. Customer service, right, which Russ told you before is very important. And now you're wasting your time, wasting that med rec time, looking in your system and telling them over the phone what this patient is on, if anything. And you do that 7 or 8 times for every patient. Big waste of time. So since the PDMP, that pharmacy director says, it saved everyone time, effort, and now they're a lot happier because you as a pharmacy tech don't need to waste your time answering what you would consider a worthless phone call for the pharmacy tech who's trying to do their job to get that patient care. It's a challenge, but the PDMP can really help with that. In reviewing the EHR, you do that anyway, but once again, it's not necessarily updated. And you have to follow those admission and discharge orders from admission, ICU, discharge, to a skilled care, long-term care, or home. And those orders can be a mess. So if you want a really successful med-rec system, you want it accurate. And this applies to anyone across the country, whether you're using the PDMP as that med-rec system or med history, or whether in your pharmacy system you have a very complete profile, but you need it accurate. And you need it as complete as possible. Now, when you're talking OTC products, you're talking vitamins or the nutraceuticals, probably not going to be in there. And you have to do those manually. And you want it up to date. Once again, the PDMP is updated within either minutes to a day. It's easy to access. What we're seeing more and more are hospitals having the PDMP integrated directly into their health record. And it's happening more and more for pharmacies too. In Nebraska, we have maybe about a dozen pharmacies doing this now. Across the country, some of you may have that. Have any of you have the PDMP integrated into your pharmacy software? Have you ever seen it? Okay. So it's a lot handier. You don't have to go to an external website, type in the patient information when you have to log in again. And your pharmacy software may not even allow, because your company doesn't allow you going to an external website, so you can't even get to it. Having this available with 1 or 2 clicks is great information to have available. And it's very cost effective. Usually it's free. And you can't beat free, can you? So here's some opportunities that I wanted to cover for what pharmacy techs can do. Now, typically you still are considered a delegate or a designee, so you have to be technically supervised by the pharmacist. Not directly one-on-one necessarily, but a pharmacist has to say, I want you as my pharmacy tech to be able to assist me, look up this information for me, and then bring to my attention if there's anything unusual or pull up the screen for me to look at. Once again, both pharmacists and prescribers, doctors, APRNs, PAs, can delegate nurses. Pharmacists would delegate either pharmacy technicians or pharmacist interns. And pharmacist interns typically cannot delegate a pharmacy technician, but they can be on the same level as a pharmacy technician. You have access to this very good information. You see, I'm trying to sell you on this throughout this, but it's very important and it's great information. You can prepare this report, you pull up the patient information, and maybe you see some clinical alerts that pop up on the system that'll say, patient has seen multiple providers. In Nebraska, we can see how many prescribers and how many pharmacists that patient has been seen in a period of time. Are they doing the doctor hopping and pharmacy shopping, or is something else going on? You can tell if they're morphine milligram equivalent, some will call it an MME or MED. So if they're on a lot of opioids, you can see if it's above a threshold that the CDC has set for guidelines. And some of your pharmacies actually restrict the number of dosage units that can be dispensed. So this goes hand in hand with a lot of company or organizational policies and what the CDC and a lot of states and payers now are restricting. And you still have to go through the prior auth process in some cases, so there are exceptions when patients actually need those. But it gives you that information, and if you see these alerts pop up, you can have the pharmacist come over and say, take a look at this. This patient has been seeing 12 prescribers and 7 pharmacies in the last month. An example that happened in Nebraska that a pharmacist told me about is in a smaller community just to the northeast of us. Patient came in, it was on either a Friday or Saturday night, which always happens, right? And just before you close, with a prescription for hydrocodone. And typically you wouldn't know any better unless you check the PDMP, which this pharmacist did. This pharmacist found in the PDMP that in 45 days, a patient had 450 doses of hydrocodone from, and I can't remember, it was either 6 or 7 prescribers and about 5 or 6 different pharmacies. And so, of course, I think it was the pharmacist, not the tech, but the tech could have found this information, let the pharmacist know, and they did not fill this. What they did is contact, when those prescribers and the pharmacies were open, to let them all know, did you know this patient had seen your pharmacy as well as 5, 6 others and all these prescribers? After that, the pharmacist told me, the patient did not show up in the PDMP again for any new prescriptions. So it's a good point. What happened? Did this patient get confronted by a provider and admitted to substance use disorder? And maybe they got treatment. And I've seen that happen. Maybe they decided that the gig is up and they would get their drugs on the street, which oftentimes is cheaper and easier than getting a prescription for hydrocodone. Maybe they were arrested because one of those providers contacted law enforcement and that patient could have been in jail. Or maybe the patient decided to get something on street, maybe some, what they thought was hydrocodone laced with fentanyl, or a stronger type of fentanyl, like carfentanil, and they died. We don't know what happened to that patient. But there's a great opportunity where you can stop some inappropriate behaviors, but try to get them help. And that's really what we want to focus on, is patient safety on this. Not to just capture and throw people in jail. They're filled already, but they need help. And then preparing that medication history, because you know everything you fill in your pharmacy, but you don't know what's being filled in the pharmacy across the street, or maybe in the pharmacy across the state border, or in another state. And so you can see all of this information, and you can bring it up to the pharmacist to ask for their assistance on, this doesn't pass the sniff test. What do you think? And let the pharmacist make some of those decisions. So I wanted to wrap it up. Got a couple of minutes here. PDMP is a very, very powerful tool. It can be dangerous too, because it does apply to HIPAA, remember, and you don't want to be trying to look up in Nebraska Governor Pete Ricketts, or in Florida Governor DeSantis, or Joe Biden, or in Nebraska Warren Buffett, because unless you have that patient-provider relationship, that's a violation of HIPAA. And there are very strict penalties. Number one, you would probably lose your job. Number two, you would probably lose your pharmacy tech registration or license. Number three, you could very easily be brought up on other disciplinary events. Number four, because this is a federal action, the penalties are up to $1.5 million per event and up to 10 years in federal prison. So you don't want to abuse the system and look up your family member or a neighbor or anyone unless there's a provider-patient relationship on that. But with this, it's got all this information in it for opioids, but oftentimes in Nebraska, for instance, all prescriptions for that comprehensive medication history. It's very timely information. Once again, no cost to query in almost every state. Easy to access, especially if it's integrated into your EHR, your pharmacy system. And this is all about patient safety, right? So we want to focus on that. This is about patient safety, to help your patients. And that's what you're a pharmacy tech for in the long run. With that, I do have my information, so if you do have any questions about the PDMP or other questions, because I'm on several national organizations and legislative committees across the country, you can email me, you can call me, and I'll be glad to help you out. Anyone have any questions? Does that seem good? Yes?
Why don't methadone or opioid treatment programs have to report to PDMP?
That's a great question. Why do methadone or opioid treatment programs not report to PDMPs? Because of a federal regulation called 42 CFR Part 2, alcohol drug programs are exempt from HIPAA and reporting to the PDMP. It's very strict. Unless it's patient consent, the patient has to give consent to release that information. The law changed last July where a PDMP can accept information from those OTPs if the state allows and if the patient gives consent. But there's some challenges with that. I'm trying to get patient consent for specific patients that are willing to do that. But I'm even working here with our addiction specialist to work with the Nebraska opioid treatment programs and try to overcome some of those barriers. And nationally, a lot of talk is going on about doing the same thing. We think eventually that 42 CFR Part 2 is going to change to totally align with HIPAA, and that's going to allow that information to freely flow into PDMPs. But it may take a little bit longer. Yes?
Do you see the PDMP, instead of being state by state, do you see that going federal?
So will we see the PDMPs going instead of statewide jurisdiction to like a national or federal PDMP? There have been bills introduced federally. It's not gone anywhere. There's still talk about that, but there's some challenges with that, especially each state has their own legislation, and that federal law can't preempt that state legislation for something like that. But there's still a lot of talk, and at some point it could happen. Mark?
What about the barriers of across the states where, like, South Dakota, of course, is one of them, where techs aren't allowed to have that access to PDMP, yet if they come into other states for us, like Colorado, they travel for healthcare, we can't see that access in there because our title is set up as techs. We can't see
Right.
PDMP.
So the question of the challenges between having pharmacy techs access PDMPs in other states. You can access it in your state, but when you try to query another state, you're restricted. It says access denied, something like that. That's state by state. Most states do allow delegates, like I said, but there are some that do not. We just ran into a situation where a border state to Nebraska had legislative changes. They no longer allow APRNs or PAs to access the PDMP. And so we're trying to work with that state on how we can work with them. Some states have those strict legislative barriers, and with some federal legislation, or at least some model rules that we are working on, we're trying to get states to have something that's more consistent and standardized. So I see that as a possibility. Probably realistically it'll be some years away, but it is being addressed. Doesn't help today, but hopefully we can get past that over time. All right, thank you very much.